was going on there. I'm going to change you to the presenter.
Okay, that's fine. You just let me share my screen as well.
Yes, I've just changed that.
Okay, let's see. Okay, can you see my slides?
Yes, thank you so much. And I'm sorry for the inconvenience, everyone. We will get Dr. Yvonne's presentation up shortly.
Okay, great. Good evening, everybody. Thanks very much for joining us this evening. Sorry for the technical glitches. These things happen every now and again. So we're just going to change the order of the talks. Yvonne was going to give a sort of general introduction to products of conception testing. And then I was asked to give a sort of interesting case study. So we'll start with a case study and then go on with the general background afterwards. So basically my talk is a case study about a rare Robertsonian translocation. If you don't know what that is, don't worry. We'll hopefully make you all the wiser in a few seconds. So firstly, just a general bit of background quickly before I get on to the case. The first thing is to say that recurrent pregnancy loss is classically defined as 3 consecutive first trimester losses or 2 mid-trimester losses. This has been the definition for many years. But it is a little bit confusing because the American Reproductive Medicine Society modified the definition recently and changed it to 2 consecutive first trimester losses for clinical evaluation, which actually ends up looking at about 5% of the population then. But they still suggested that you should look at 3 losses for epidemiological evaluation, which is about 1% of the population. So basically, this means quite a lot of gynecologists will refer patients even after 2 first trimester miscarriages for assessment. And the case I'm going to talk about includes elements of reproductive, recurrent pregnancy loss, which is why I'm mentioning this. So first of all, when you have a miscarriage, a lot of the time it's a sporadic pregnancy loss. So not patients having recurrent pregnancy loss, just a general miscarriage. A patient has a miscarriage in between pregnancies or for the first time that she's pregnant. And if you do pregnancy products of conception testing, so you take the products and send them off for genetic chromosome analysis, you'll actually find even in sporadic pregnancy loss, about 60% of the samples tested will actually have a chromosomal anomaly. And so it's extremely common cause, most common cause of miscarriage. And obviously, if you look at age, miscarriage rates increase. And this is because of chromosomally abnormal embryos or aneuploid embryos. So on the graph below, you can see, if you're young, under 30, your pregnancy rates somewhere between 10 and 20%. But as you get older, over 35, then the pregnancy rates start escalating. And at 40, then you already up to about 25, 30%. And when you get to 45, it's close to 60, 70% chance of having a miscarriage. So what about genetic testing and recurrent pregnancy loss? Well, products of conception testing is recommended in patients with recurrent pregnancy loss to see whether there's a genetic cause for the miscarriage or whether there's something else going on in the patient, such as an autoimmune disorder or an abnormal uterus or some other cause of recurrent pregnancy loss. Now, when you test products of conception, you might do it via an evac, so you do an evac procedure and send it off. Some people even can do a hysteroscopic biopsy of the pregnancy sac. This might be relevant if there's a twin pregnancy and you want to check the genetics of each twin. It can also be done these days. A lot of the time, we're trying to avoid doing too many evacs because we cause adhesions in the uterine cavity or scar tissue in the uterine cavity. So sometimes we give patients medical treatment so they can have a miscarriage at home. And it is possible still to collect the products of conception at home and courier to a genetics lab. And Next Biosciences are very helpful with this. And you do have to sometimes consider maternal contamination if you get 46XX result, and there are various ways of possibly getting around this as well. So the one aspect that we can talk about is testing products of conception. The other aspect is looking at the parents themselves, which is parental karyotype testing. And this is also recommended in recurrent pregnancy loss. And this is specifically to look for translocation abnormalities. Now, translocation abnormalities, I'll explain what it is in a second, but it affects 2 to 5% of patients who are having recurrent pregnancy loss. So what is a translocation? So people sometimes talk about a reciprocal or balanced translocation. And what does this mean basically? So what it means is that you get 2 chromosomes. We obviously have 46 chromosomes. There are 23 pairs. So the first 22 are autosomes, like 2 pairs of number 1, 2 pairs of number 2, etc. But you can get basically between 2 different chromosomes, like say chromosome 14 and chromosome 21, for example, you can get genetic material that's swapped between the chromosomes, which is an abnormality that can occur during reproduction. So you get a break in each chromosome, and as you can see here, the green chromosome gives a piece to the red chromosome, and the red chromosome gives a piece to the green chromosome. So they basically swap pieces of chromosome, which is what's called reciprocal translocation. But the actual number of chromosomes is the same. You still have 46 chromosomes, just that you've switched a piece of genetic material between the 2. And this is something that most of us understand, this type of translocation. And if at the end of the day, what we normally counsel patients is that if this were to occur, and either partner, they would have 50% chance of having a miscarriage. So automatically of their gametes, 50% would cause a miscarriage. And basically when you look at it, remember you've got a normal one and an abnormal one for each group of chromosomes. So when you're working out the different possibilities, you might give the normal chromosome to your gamete, or you might give the abnormal chromosome. And that occurs with both the different pairs. For example, the 2 21s could get either a normal one or an abnormal one, and the 2 14s, for example, could give a normal chromosome or an abnormal one. And then basically when you look at the net result at the end, you could get lucky and get both the normal ones. You could get a balanced translocation carrier, meaning that all the genetic material is there and the person's actually got, but still carrying the actual translocation. And then you can get an unbalanced situation where you get extra pieces of chromosome, and this will automatically result in miscarriage. So it's basically 50% chance of causing a miscarriage. And this is often what we expect. We'll have to explain to patients that 50% of the time they'll have a miscarriage, and if they have a child, they may be a carrier or may be normal. So what is a Robertsonian translocation? So normally when you ask doctors what's a translocation, they go as far as the first part, and then after that their brain explodes, and they can't remember what's a Robertsonian one. So because we can't remember more than about 72 hours all this genetics. So I'm going to try and make it easy. So the chromosome types, first of all, when you talk about a Robertsonian one, it involves a certain shape of chromosome. So you get chromosomes with different lengths of arms, and there's an acrocentric chromosome which has got short P arms, and these are the ones actually that cause a Robertsonian translocation. So what happens basically is the chromosomes that have got a short P arm, the P arms actually almost like disappear, and then the long arms of 2 different chromosomes get stuck together. So this bit of material that's lost doesn't really affect the phenotype. It's not much genetic material. And then the other bits to get stuck together. So the phenotype of the adult in front of you will be normal, but they will have actually lost a little bit of genetic material. And because they've joined 2 chromosomes together, they've lost 1 chromosome. So basically they've got 45 chromosomes and not 46. So basically, remember, it involves chromosomes with a short P arm, and I've listed the acrocentric chromosomes over there, 13, 14, 15, 21, and 22. And once you've joined 2 together, you're going to lose 1 chromosome. So you're going to have 45 chromosomes. Now, the times when these things normally get joined together, the most common sort of chromosomes that join together to make this new chromosome, they call it a derivative chromosome, is 13 and 14, 13, 21, 14, 21, 15, 21, and 21, 22. So these are quite well described Robertsonian translocations. So with that bit of background, I just want to tell you one more thing, sorry. If you've got your Robertsonian translocation and you look at all the different options for what could happen with the child, again, you can get normal, you can get a balanced translocation, you can sometimes get an unbalanced translocation with this new derivative chromosome there and get an actual trisomy. And about Down syndrome, about 3% of them are actually a Robertsonian translocation. So it's interesting because sometimes when people tell you they've got Down syndrome, you say, no, it's just sporadic, it won't happen again. But actually a certain percentage of them are related to an unbalanced Robertsonian translocation. And then you can get, again, the unbalanced version where you're going to end up having a miscarriage. Okay. So basically, what will happen when you do the products of conception testing? So if you do the products of conception testing and you're looking at the actual abnormal tissue, you're either going to get a trisomy or you're going to get a monosomy. The trisomy is with the new derivative chromosome extra, and the monosomy means there's nothing there. So nothing was carried through. Okay, so let me do my case study, and with that background, it'll help you a little bit to understand it. So basically, the case I'm going to present is a 30-year-old woman who presented with 1 year infertility. And when we tested them, the female partner had polycystic ovary syndrome, but she did ovulate quite well on clomiphene citrate. And her AMH level was 5, which means that she had got higher than normal number of eggs, because the normal AMH is about 1 to 3. So this also fitted in with her polycystic ovary on ultrasound. She had a normal hysteroscopy and laparoscopy, so there was nothing physically really there, and she had a normal body mass index. So that was the story on the female side, but on the male side, there was an obvious sperm problem. The sperm count was very low, 6.3 million, and the normal is about 15 million. And there was also reduced motility and shape morphology of the sperm. So with a severe sperm problem, we recommended IVF treatment for this couple. So we did 2 egg retrievals on the woman. As you can expect, she made quite a lot of eggs with her polycystic ovaries, and she had very good numbers of blastocysts. So the eggs were fertilized, they grew very well after 5 days into blastocysts. And then we transferred these blastocysts into her, either with fresh transfers or the embryos were frozen and transferred afterwards, frozen embryo transfers. There was no genetic testing done in this particular patient. When we look at the results of the transfers, it's quite interesting. Now, she had quite a number of transfers because of the embryos. You can see she actually conceived with every transfer except 1. So she got a positive pregnancy test with all these transfers, but there was a pattern of having either miscarriages when she got to 8 to 10 weeks. So there's like 1, 2, 3, 4 of those where she got to 8 to 10 weeks. And then also another 4 that were early miscarriages. They stopped just after the positive pregnancy test. The pregnancy level would go down and she had stopped between 4 and 5 weeks. Now, 2 of the pregnancy where she had the miscarriage, pregnancy tissue was sent off. The first one showed a trisomy 14, but also a triploid embryo. And the second one that was sent off showed trisomy 14. So although the patient initially presented with an IVF problem, obviously when we saw this, we realized, no, there's something going on genetic here. This patient's got some kind of recurrent pregnancy loss problems, most likely genetic. And therefore we sent a carrier type for both parents. So instead of now looking at just the products of conception, we wanted to look at the parents as well. Now on the female side, the female partner had a normal carrier type. But what was extremely interesting was on the male partner, the abnormality that he had. So what he had, basically, he had a 45 chromosomes, meaning 1 chromosome was missing, which is consistent with a Robertsonian translocation where 2 chromosomes are stuck together. He was XY, so 6 chromosomes were basically normal male. And then this new chromosome, the DER is for the new derivative chromosome, was made up of 2 14 chromosomes stuck together. Now, this is highly unusual because normally when you get a Robertsonian translocation, it's between different chromosomes, 13 and 14, or 14 and 21, or 21 and 22. So normally you don't get the same chromosomes sticking together. And I'd never seen anything like that, and I also didn't understand immediately what the implications would be. And even when I spoke to many of the geneticists, they explained to me that they haven't seen it either, you know. So it was really a strange, rare Robertsonian translocation between the 2 14 chromosomes. So what were the implications of this? Well, the implications are basically that there's no normal 14 chromosomes left, because both of them are stuck together to make this new derivative chromosome. And this is a problem because normally when you get a translocation, you still get a normal chromosome and you get the abnormal one. In this situation, there's nothing normal left to transfer into the gametes. So it means that, you know, either the gamete's going to get nothing, you know, or it's going to get both the 14 chromosomes. And in the end, basically, when the embryo is formed, including genetic materials from the normal partner, you're going to end up with always either a trisomy 14 with the abnormal derivative chromosome present, or you're going to have nothing there, and then you'll have a monosomy 14, which is when there's an absence of that derivative chromosome. So in this case, basically, you know, it's not possible to get any normal embryos, which was a strange and difficult thing for me, because I've even told the patients before we tested them that if we do the karyotype and there's a balanced translocation, at least there is a 50% chance, and there might be a way of identifying the embryo with PGT, for example. In this case, basically, we had no way of using his sperm because we would always end up with a genetic problem, and we had to explain to him it's not possible to reproduce with his sperm. So we recommended donor sperm for him, and that's basically what we had to move on with. The other interesting thing was the male partner opted for a vasectomy because he didn't want to have a future accidental pregnancy with his wife where she would end up having a miscarriage automatically. So, yeah, what can we learn from this interesting case? I mean, I think there was quite a lot of learning points, and you know, when you go with a retrospectoscope through one of these cases, there are clues that pop up all the way along. You know, one interesting thing is, for example, that it's actually known that if you have a balanced translocation, quite a lot of the guys actually have oligospermia, so which he had in the beginning. But if you pick up, one of the things I'd like to say is, if you pick up the same chromosomal abnormalities on your products of conception testing, then consider karyotyping the parents. So normally with sporadic miscarriages, you'll get all different things. So if you start seeing the same abnormality reported on products of conception with different miscarriages, you should possibly karyotype the parents and look for a translocation. The other thing is that sometimes you're going along one direction and you have to change course, and that's kind of what happened here. Our initial diagnosis was infertility, and we did that type of testing. But as we progressed, we realized the patient kept having miscarriages, and we had to change and put it into the new basket of recurrent pregnancy loss and start testing them for those abnormalities. Pre-implantation genetic testing is where you do genetic testing on the actual embryos. And certainly in this case, if we had done PGT, we would have been alerted earlier to the diagnosis of the translocation, because we would have picked up quite a lot of embryos with trisomy or monosomy 14. At the time that we started doing this particular case in 2018, PGT, there was still quite a lot of controversy about whether it was useful to do. You know, there was quite a lot of suggestions that you couldn't really improve the overall pregnancy rate anyway with PGT, and possibly it could reduce the pregnancy rate by you excluding certain embryos from the mix. However, I think PGT in IVF is becoming utilized more now, and there's a few reasons for this. One of the things is that we've got more clarity in terms of the predictive results if we get an aneuploid diagnosis. So we biopsy an embryo and we get an aneuploid diagnosis. We know from a study by Richard Scott that if you put in, they put in 100 aneuploid embryos on a blinded trial, and none of them formed a live birth. All of them either formed a negative result or caused an early miscarriage. So we're more confident now that if we get an aneuploid result in IVF, that we can exclude that embryo. The other thing is with patients who have got many embryos and we test them, instead of doing many frozen transfers like we did in this patient, we would exclude all the aneuploid embryos, and we would probably do a lot less transfers and possibly even save a bit of cost in terms of all the frozen transfers. But the other important thing is for the patient, it might save them having extra miscarriages, which can be quite hard for them as well. And the last point about why PGT is being used more, I think, is we're getting more information about mosaic embryos. Mosaic embryos are embryos with different genetic makeup, and it's been shown now recently at the latest X-ray that if you have mosaic embryos with less than 50% cells abnormal, you can actually transfer these embryos, and none of the children born from the big study that was done from 1,000 mosaic embryos actually had any abnormal children born. And actually the pregnancy rate's lower than the euploid embryos, but not that much lower. So these things helped us a bit with PGT in terms of utilizing it more. So I think this case was quite interesting because it looked at products of conception and started the discussion around that. Then we ended up doing karyotyping on the parents and found some really interesting results there. And obviously we then looked at the role of PGT in this type of patient. So we're looking at all the different types of genetic testing and how they link together. So that's the end of my talk, and thank you for listening. And I'll now let you go back to the organizer to do the next talk. Thank you so much.
Thank you so much, Dr. Le Roux. That was a really, really interesting talk. I have one question here for you quickly. Sure. Can you routinely test POC from a hysteroscopy, as you seem to have mentioned?
I think the idea about that is like a targeted biopsy. So what it's sometimes used in twins where you put the hysteroscope in and you'll actually see the two sacs in the uterus, and you can biopsy the one sac and then you can go and biopsy the other sac as well. But obviously you have to biopsy the actual pregnancy sac. So most of the time evacs are done and not hysteroscopies, but sometimes people do go in and biopsy the actual pregnancy sac. And in a way it's good because you're making sure that you're getting tissue from the sac and not the maternal tissue.
Okay, and I have one more. Would you advocate for full genome POC screen rather than a test looking at selected chromosomes?
You're asking, I think the question is, should you do all the chromosomes or should you only do the chromosomes with
selected?
Yeah, so basically the chromosomes that people worry about, you know, because let me just say in nature, most of the time, if you've got a chromosome abnormality, nature is very good at stopping the embryo either implanting in the first place, so you get a negative test, or if you get pregnant, most of the time in the first trimester, the baby will miscarry. Now, there's certain chromosomes that we know well that will continue after 13 weeks, and those ones are the 21s, the Down syndrome, Patel syndrome 13, 18 Edward syndrome, and the sex chromosomes like Turner syndrome. So those type of chromosome abnormalities can grow on. And in the past, a lot of the time, genetic testing was focused on those particular chromosomes. But obviously, if you're testing for a miscarriage, it could be any chromosome that's abnormal. So if you only test for those four chromosomes I mentioned earlier, you're going to miss many genetic causes of miscarriage. So I don't think it's very valuable, because if you get those, if you test and only ask for those chromosomes and they come back normal, it doesn't exclude a genetic cause for the miscarriage. So I think if you're doing products of conception testing, you should check all the chromosomes, otherwise not very useful. I hope that answers the question. Thanks.
Thank you so much, Doctor. So Kelly Logenberg, our genetic counselor, will be stepping in for Dr. Yvonne and will be doing her presentation now. Thank you so much, Dr. Le Roux.
My great pleasure. Thanks.
Right, I hope everybody can hear me. Good evening. Thank you so much, Dr. Le Roux, for that very interesting case. I know at the time it was a very unusual one, but did show the benefits of POC screening. So although the order is a little different, I'm going to quickly give you an overview of our products of conception testing. So we offer this testing to all patients who've suffered a miscarriage. Obviously, this can happen at any stage, at any gestational age. We use next generation sequencing technology, which allows for the detection of chromosome abnormalities on any chromosome. We don't need to do cell culturing, which allows a quicker turnaround time and very little to no technical failures. So what I'll be discussing this evening is our statistics from the testing that we did in 2020. So for last year. This slide just gives you a quick overview of exactly what we can see. So we can detect full trisomies, monosomies. We can see segmental deletions and duplications larger than 20 megabases. sometimes even smaller than that, depending on the quality of the tissue that's received. Our turnaround time is generally about 7 to 10 days. And then, as you know, we have an in-house genetic counselor to support either the healthcare professional or the patient if there are questions. And then we have a client services team who are able to assist with medical aid authorization. So if we move on to the results from last year, if you have a look at the data set from 2020, we found that approximately 50% of early pregnancy losses were due to chromosomal abnormalities. And this is very much in keeping with published data. We had on our test no failures because we were using NGS and next generation sequencing. And when you compare that to conventional karyotyping, we know that the failure rate can be quite high because of the cell culturing. So some publications will quote as high a failure rate as 10 to 40%. Moving on to the results per maternal age group. So as Dr. Le Roux also mentioned, we know that the rate of chromosome abnormality does increase with maternal age, and this is due to aging oocytes. So in our data from last year, we very clearly saw this, as you can see on the slide. So I'm not sure how the colors are showing on your screen, but aneuploid results are showing in blue, euploid or normal chromosome results showing in green, and then mosaic in red. So our data showed that in pregnancies where the maternal age was between 46 or 51, there was twice as likely to be a chromosome abnormality as to have euploid results. Although even in younger age groups, we know that chromosome abnormalities can happen at any age. And even in the younger age groups, we did see a significant proportion of aneuploid pregnancies. If you look at the results per gestational age, we see that as the gestational age increases, the frequency of aneuploid results decreases. So, and the reason for this is we know that aneuploid pregnancies are usually not compatible with life, and they will often result in early pregnancy losses. So full chromosome abnormalities are less likely to be the cause of miscarriage further along in the pregnancy. There you may sometimes see segmental or a mosaic abnormality, except for those specific ones that Dr. Le Roux also mentioned, where you can see a pregnancy with trisomy 21, 13, or 18 progressing a little further. Okay. So if we have a look at the different types of products of conception and the referral reasons. So if we start with the different, the common reasons that we get referrals for products of conception testing, this graph indicates the frequency of the different referrals and what the results were based on that indication. So again, the dark blue is showing the aneuploid results, the light blue is showing euploid results, and then in red is the mosaic. So you can see that the most common referral reason is recurrent pregnancy loss, but then we see quite a number of other referral reasons also. So we see aneuploid results for all the indications listed. So if there's a history of a genetic imbalance, so if one of the parents carries a translocation, for advanced maternal age, if there were abnormal features noted on ultrasound. The only exception to this in our data set were molar pregnancies. And we know that we have to acknowledge that the presence of a molar pregnancy can't be excluded if a euploid result is reported. So just a little bit of background about a molar pregnancy. A molar pregnancy is the result of two haploid sets of chromosomes that both originate from one parent. So for example, an empty egg cell that's fertilized by two sperm cells. So you still have the correct total number of chromosomes, so the chromosome number is unaffected, but karyotyping or sequencing won't be appropriate to confirm or exclude a full molar pregnancy. A partial molar pregnancy we may be able to detect because you would expect those to present as a triploid pregnancy, or as a triploid chromosome result. So the tissue types that were identified by the lab, so before we do any kind of chromosome analysis or sequencing, the tissue that's received is visually assessed by our medical technologists in the lab, and the most frequently found tissue type by far, as you can see, is chorionic villi, and this is followed by unidentified products of conception in about 12% of samples. So in these cases, the tissue that was received by the lab cannot be clearly identified, and it's possible that it may be maternal in origin. Ideally, we would want to test fetal tissue as it's the most representative of the fetal chromosomal complement, although chorionic villi is a good second option if fetal tissue isn't available. But there are limitations because it originates from the placenta. There may be confined placental mosaicism, and there could also be maternal cell contamination. So if we look at the unidentified products of conception that were assessed, what the lab does is they look at the tissue, they dissect it as far as possible to exclude maternal cell contamination. And we know that maternal cell contamination is the most common reason for a decrease in the number of abnormalities detected due to an over-reporting of the euploid female profile, which in fact is the maternal genome. So if we look at our EUPOCs from 2020, we found euploid female results in 94% of unidentifiable POC samples. And in those cases, maternal cell contamination can't be excluded with absolute certainty. However, in about 6% of cases, we saw a euploid male or aneuploid result, and this included mosaics. And that information is really valuable for that subset of patients. So if we look at the various abnormalities that we detected in our data set from 2020, you can see that there's a good spread, and trisomies are, as you would expect, identified in about 66% of pregnancies, so it was the most common abnormality detected. It is important to remember that we can't detect all types of polyploids with sequencing technologies. So for example, we can't detect all triploids. We can only detect it if the karyotype is 69XXY, so if there's a Y chromosome present. If it's triple X, we won't be able to detect that. So we do know that triploidy is a frequently observed anomaly, especially in first trimester losses. And then structural chromosomal rearrangements, which are balanced, so a balanced translocation, also can't be detected by sequencing because all the genetic material is still present. But this isn't expected to be a significant contributor to pregnancy loss because, again, all the correct genetic material is present, it's just in the wrong place. So you wouldn't necessarily expect that to result in a pregnancy loss. So if you have a look at the different chromosomes involved, monosomy X, as you would expect, is the most common aneuploidy that we've seen. So we know that only about 1% of Turner cases will carry to term, and the largest proportion will end in an early pregnancy loss. So in a close second to monosomy X, we found trisomy 16 in the most number of samples that were assessed. And then in some cases, there were more complex profiles which suggested the potential inheritance of a unbalanced translocation from a parent that may be carrying a balanced translocation. So where we saw a segmental gain and or loss in some cases. So in those cases where the lab detects a gain and or a loss in a products of conception test, the report will state that further testing may be warranted. And we are always available, the lab manager and myself are available to discuss these more technical cases if there are any questions about the results and what the follow-up should be. And we often on the reports, as you may have seen, suggest that the patient be referred for genetic counselling to discuss whether any further testing is warranted. So if you have a look at the chromosomes that are involved in the different trimesters of pregnancy, you can see quite clearly how, again here, the blue is indicating first trimester losses, and then the green, which I hope you can see, is indicating second trimester losses. And you can see how it changes from the first to the second trimester miscarriages. So in the first trimester, you can see anomalies for all chromosomes. You can see a spread there across all the chromosomes, whereas in later gestations, we see mostly chromosomes 13, 18, 21, and then the X chromosome involved. Right, so those are our results from 2020. And then just to end quickly with medical aid coverage. So our client services team takes on the process of assisting patients with medical aid authorizations to determine whether this test will be covered. If it's not covered and the lab can't identify suitable tissue for testing, we do present the option of cancelling the test before there's any cost incurred for the patient, and this will be discussed with the healthcare professional. And this saves the patient an out-of-pocket expense with that has a high probability of not receiving an interpretable result. Okay, thank you so much for listening, and I'm very happy to take any questions that you may have.
Thank you so much, Kelly. I have one question here. Should the test pick up a translocation, can Next Genetics assist with genetic counselling for my patients?
Yes, so if we detect a gain and or a loss on products of conception testing that may indicate one of the parents carry a balanced translocation, we can certainly assist with that. So depending on where the patient is located, we will put them in contact with a genetic counsellor in their area. Alternatively, I'm also available to assist with these cases, but we do encourage the doctors to get in touch with us to discuss these on a case-by-case basis. If they would like a referral, we can certainly assist with that.
Thank you so much, Kelly. I don't have any other questions. So I would like to, I'm going to stop sharing now. Okay. Okay, and then I'm going to, Dr. Majachani is going to speak to us on POC screening and how this is beneficial to your patients. So I'm going to hand over to him. I don't think he doesn't have any slides, but he will be switching on his camera and speaking to us. Thank you, Dr. Majachani.
Good evening, everyone. Thanks for coming in. I don't know whether you can hear me loud and clear.
Yes, we can hear you perfectly. Thank you.
Great. I've been asked to talk about the value of providing answers after an early pregnancy loss. I work from Sunninghill Hospital, and we've got a busy emergency department where lot of women come in with pregnancy losses, early pregnancy losses. A number of them which are not known to us as a team of gynecologists from our hospital, but we get to see quite a bit. And so talking about the value of getting answers, of providing answers to these patients, it's always a difficult topic to do, and talking about miscarriages is a very uncomfortable topic for most people, including myself. And women who have had miscarriages are usually reluctant to talk about their experiences and to share their feelings. And it's understandable when they don't talk about their experiences clearly. And what we find a lot is when you ask patients about the reason for their miscarriages. I mean, all of us gynecologists deal with this on a day-to-day basis. And when you inquire and ask them to say, do you know what caused your miscarriage, to a lot of these women, and the paucity of information which comes through is astonishing many times, to say the least, that a lot of them will say, I was never told, I don't know, there was a cause for my miscarriage. And these women feel a lot isolated and very fearful, heartbroken, and sometimes they feel very guilty that they could have caused these miscarriages. So when this happens, there's a lot of questions which these women and those couples ask when a miscarriage, early miscarriage happens. Questions like, did I do something wrong? Or is something wrong with my body? Can I get pregnant again? And if so, when can I try? When is the best time to try? So there's, but of all these questions, the most important question for these women and couples is, why did this happen? And unfortunately, this is a very difficult question. It's very difficult for most of us. On the question of why, I think there was a research which was done to try and find out what do common men in the streets think are the reasons for miscarriages. And the top 7 answers were very astonishing, you could say the least. People would say, oh, maybe a traumatic event somewhere could have caused this, a stress-related event. Lifting up objects in your house or in your garage can cause this, an STD, a previous termination of pregnancy, an IUD. These are some of the reasons which came up. Even if a woman doesn't want a pregnancy, she will end up with a miscarriage. So you will find that these reasons, which it shows that how people are misinformed. When women have got a first trimester loss, they have a lot of anxieties, because it could be any one of these things. But you and I on this panel, on this floor, know that these are not the reasons for most of these first trimester miscarriages. But it is important. The question of why did I have a miscarriage is important to these women, because it helps them to a sense of closure and possibility of a solution, to come up, for anyone to come up with a solution, someone to come up with a solution, and to plan their way forward, going forward, in case for those who want to get pregnant in the near future. The truth is that there are many causes for miscarriages, and we know that there is those uterine abnormalities, cervical abnormalities, immunological disorders, autoimmune problems, which anyone can develop, hormonal problems like diabetes and thyroid problem, advanced maternal age, even paternal age comes through. Toxins, including smoking, alcohol, medication, and even environmental toxins can cause miscarriages. But however, the vast majority of these miscarriages are from a chromosomal abnormality, as Dr. Le Roux highlighted, and came up with 60% as the reason for most of these first trimester miscarriages. And he also highlighted that nature is very vigilant on all these conceptors to find if there's an abnormality. Nature has got a way of getting rid of this. But in trying to answer the question why to most of these women, we try and emphasize that it is not always possible to find an answer, because some of these things you can control some of these causes, like the smoking, the alcohol, the environmental exposure. You can control for those, but there are some things which you can't control for as a woman, like if you're born with abnormalities or with anatomical abnormalities, or if you developed a chronic disease like diabetes or autoimmune disease in your childhood or in your adult life. You can't control for those things. And sometimes people, these days we see women who start their families quite late in life, and you can't control that for some religious reasons. Some people start families late. But because the causes cannot always be controlled, I tend to tell my patients that they shouldn't feel guilty, because a lot of times they come with a sense of guilty, and we say we need to do some investigations, and these investigations can be pointed towards whatever we think has caused the first trimester miscarriage. And we reiterate that it is not always easy to find an answer, but the easiest or the commonest which we do is POC screen for first trimester miscarriages, and it does help us find some answers. And when you do these investigations and you have got an answer as to what could have caused this miscarriage, it brings a lot of relief on them. So there's value in trying to find answers to first trimester miscarriages. And like I said earlier on, the paucity of information when someone has had a miscarriage is astonishing. We find lots of people don't know why, what could it, and because you don't know, there's a lot of psychological problems on these patients. There's depression, there's anxiety. Even in the next pregnancy, when they get pregnant again, these couples, there's a lot of anxiety because they don't know what could have caused the first one. And so, in a nutshell, we find value in trying to find answers to all miscarriages which happen, and we try and investigate them. It helps with future outcomes. It helps patients to adhere to pre-pregnancy advice, because at least you found something in there, and patients tend to come back even if they've told them that there's things which they can't control themselves. So what can we do? Is there anything we can do when someone has had first trimester losses and you're trying to find answers to, and what advice do we give them? Usually we give them the general advice where we say, okay, must eat a balanced diet. Everyone says, what is this? But we have to give them that kind of advice. Maintain a normal body weight. For those with chronic conditions, we try and optimize them. We try and optimize them in terms of their chronic condition. And for those with recreational bad habits, so to speak, you would say, stop the smoking, stop the alcohol, treat yourself like you are pregnant, and that in so doing, you help the next pregnancy when it happens. For those with environmental toxins, find ways of eliminating them. And pre-pregnancy, we advocate that they take adequate amount of folic acid, and so there is value in trying to find some answers to a first trimester miscarriage. We cannot just say, oh no, that was a miscarriage, and dust off, you get pregnant in the future. And so in a nutshell, we find a lot of value in trying to find answers to these first trimester miscarriages. Over to you, our organizers.
Thank you so much, Dr. Majachani. You really have highlighted the value that finding causes for early miscarriages have for your patients. I think especially the psychological values is often so important for patients to be able to provide an explanation in some of these cases. I'm just checking. I don't think we've had any questions that have come in. We'll give it one more second. But I'll just take this time then to say thank you so much both to Dr. Majachani and to Dr. Le Roux for giving up their time this evening to talk to us. And thank you all for joining us. A recording will also be sent to everybody that attended and that registered. Thank you so much for your time this evening.
Thanks, Kelly.
Thank you, Kelly. Thank you.
That's a pleasure. Bye-bye.
Bye.